Good morning, everybody. I'm Ben Hostrald with the Forum for Collaborative HIV Research, and I'm here to introduce the rapporteur presenters for the category breakout sessions that took place on Tuesday. The first category is Category A, Routine and Expanded Testing, and the rapporteurs are Donna Futterman of the Adolescent AIDS Program and Jenny McFarland of the Texas Department of State Health Services.
Good morning, everyone. Wow, what an exciting time we've had in a very early morning to get up and start reviewing all that we've learned and all that we've seen. Dr. Futterman and I were fortunate to be able to attend the Category A sessions, and we're going to talk with you today about what we observed, and our dear colleagues, our helpers, Navita and Eric, assisted us with compiling our slides, so we extend our great appreciation to you all for helping us summarize these documents. So we started with the first session, which I was fortunate to co-moderate with Dr. Bernie Branson, and we talked about the new algorithm for HIV testing that has been proposed and is waiting final approval. And a couple highlights for the algorithm was the identification of stage 0 for acute HIV infection, and also the HIV-2 case definitions, and the algorithm really using the idea of the fourth generation or combo testing and then following up with a multi-spot or some sort of differentiation test. We also discussed the use of electronic medical records in doing a case review for determination of previous HIV status to help clinicians, but also help facilities determine whether or not they need to do testing for their patient population. The other idea discussed was the role of kiosks when it comes to assessing someone, assisting a patient with their opting into testing, but also with their previous test history and collecting even risk data. And the other interesting issue regarding this session, or the overall point, was that using multiple strategies when it comes to not only new diagnostic testing that's being developed by existing companies, but also new models when it comes to HIV testing, including our friends in El Paso who described their process in the emergency center there. One thing that we were curious about and would like to learn more about is when it comes to algorithms, the role of dual rapid testing. And I'll let Dr. Futterman proceed. Oh, sorry. Oh, yes. Thank you. The next session was regarding HCV diagnosis in the birth cohort testing. And interestingly, we do know that the birth cohort new recommendations is strongly suggested because it will capture over 77% of persons who have HCV, so really exploring the new alternatives with using the birth cohort indicators, and also looking at what the VA has done in their testing. And once again, the challenges with uptake of HCV testing and the discussion around how we've been in a similar place in the past when it comes to HIV testing, and how we can apply our lessons learned with what we've gone through with adopting routine HIV testing and assist us in taking on routine HCV testing using the birth cohort algorithm.
Good morning, everyone, and thank you to the Summit for presenting a tremendous conference. As you can see, there was a tremendous amount of diversity and interesting presentations in sessions, in the A sessions. In this third session, in which we discussed models for HIV and HCV testing, the first presentation was on the unknown impact of the new home-based point-of-care testing licensed by the FDA. We don't know yet what the number increase will be or the linkage to care rates will be with home-based testing, and that will bear follow-up. The next two presentations were on the implementation of HCV rapid testing and certainly the acceptability of rapid HCV testing for patients, and there were two cohorts that were looked at. One was a group of injection drug users from California, and the other was about 2,000 people in New York. And the New York study highlighted the challenges of getting people who test preliminary positive back for their confirmatory test, to take a confirmatory test and to get those results. And again, the notion of two rapid tests being used, which is the method of most of the rest of the world for HIV testing, can be further explored for HCV testing. Then we heard 4 different presentations on routine testing implementation challenges. The first was from Montefiore, where I work, and it was a summary of 10 years of initiatives on provider-based testing in a changing environment of testing, going from a purely voluntary system in community health centers to now the New York State mandated. And one of the things that really came up from that was, one, the sustainability of a provider-based model, but two is what is really our expectation of routine testing? What is the upper limit that we can realistically get to? And on an annual basis, how many patients will that be? And the other question is, how do we monitor really not just the annual numerator data, but looking at percent of patients in the institution that ultimately are tested? A very interesting study from the PZD in DC found that a dedicated tester model, which did pretty well in the PZD, was far surpassed by a provider-based model. Once the dedicated tester was removed, the testing completely fell off in the PZD, and the new provider-only model really surpassed that with much, much higher rates. A wonderful program in Philadelphia showed the benefits of a full-court press on testing, everything from neighborhood knocking on doors and leaving behind cards to social marketing to vans to linkage to care in a single zip code. Again, certainly including all the elements, but how fundable and sustainable. And then another emergency department in Philadelphia taking on the offer of testing to sexual networks. So that's EDs going above and beyond. And they found that their most success was through a referral-based card that drew in the most people for testing, for partner testing.
Our next session was regarding testing and integration in primary care settings, and we had a great discussion and great overview about the challenges in provider-initiating testing, and a fantastic review about what is happening among providers that is influencing their inability or their lack of uptake of routine HIV testing, especially among Black physicians. And a thorough study was done with the National Medical Association and Black physicians specifically. And what we saw from this data was a real reflection of cognitive dissonance, because the physicians talked about how high risk they thought their patient population was for acquiring or living with HIV. However, they were doing such low testing rates. And how can we work with influencing clinicians overall, but also among educating clinicians about how this is affecting your own community. We also talked about the effect of policy changes on integrating HIV testing in primary care. The large FQHC system in New York used a great quality improvement process to show their clinicians how they are doing actually on implementing or offering the HIV test and then actually doing the testing. So I thought that this quality improvement process that the group is doing at the FQHCs was quite effective, and I liked the idea of them doing a little bit of competition among their providers to show how each of their peers are doing when it comes to not only offering, but also the end result of actually their patients getting tested. And we also talked about, again, how can we ride this wave of getting HIV, routine HIV testing implemented, but also adding in with the appropriate patients in the birth cohort, the HCV testing. And we had a quite vigorous conversation about the idea of opt-in and opt-out. And what is this idea of offering versus informing the patient that they'll be tested, and what your local jurisdictional laws say about how you must perform testing. And we discussed the history of why we needed these thorough consent processes, and understandably there have been a time where we needed the thorough consent process due to discrimination stigma. But moving forward, and how can we affect change with this consent process, and is it really a true barrier to clinicians performing routine testing? So we had, again, an excellent discussion regarding all of this and how we can move forward and influence administrators, clinicians, and practices overall. And also we discussed the idea of, Dr. Fitzpatrick brought up the idea of, are we waiting for the lawsuit of the missed opportunity, the missed case because you did not test?
And the final session was on policy issues affecting both HIV and HCV testing. The first report was by Dr. Richard Rothman, who talked about the emergency departments being central to the CDC strategy on routine testing and missed opportunities, yet a pullback of the funding, and we really haven't settled on what is the best methodology, dedicated testers versus integrated. So this remains a challenge, an unfulfilled situation in the face of dwindling funds. The VA policy change in 2009 mandating a routine testing led to a doubling of tests, but again, they didn't come close to achieving routine. We heard the news that following on the National HIV/AIDS Strategy, HHS has recently released a comprehensive action plan on viral hepatitis, so we should be seeing more implementation through that. A very interesting talk on the impact of the U.S. Preventive Services Task Force mandating, or not mandating, grading of HIV testing as a grade A recommendation, and the hoped for impact of that within the environment of the Affordable Care Act. This was really a crucial step, and I think the hepatitis folks are feeling certainly bereft that their routine testing recommendation did not get the same strength. NASTAD did a survey of state health departments on HIV and HCV and noted, again, the increasing need for testing, but this era of constrained funds. And so I think the sum total of those presentations made us really challenged to say what kind of effort, money needs to go into testing versus the rest of the healthcare continuum on HIV, and yet another reason to say routine is routine, and how do we get to the routine of other healthcare tests. An almost comical 5 minutes on Europe, a very big place, showed that 33% of people with HIV are estimated as still undiagnosed, and about 50% are late presenters with a definition of a CD4 under 350. And again, reports on structural barriers for access being the prime drivers of difficulty for injection drug users getting tested. There are certainly some fears on the part of IDUs, but really it's the structural barriers that weigh heaviest. So in summary, I think our track showed that there are multiple models to trying to scale up routine testing, but we've not achieved it yet. We're actually quite far from anyone, anywhere, really achieving routine testing. It's much longer than many of us anticipated, and I think we're all challenged to look at this from the perspective of the non-HIV clinicians. From our world, it seems like this is a no-brainer. We should be able to do it, but looked at from the point of view of other clinicians, this has not been a no-brainer and not something that's been adapted. So how do we really rethink what should be in on testing and what doesn't need to be in, and really reconceptualize, I think, what we want to be doing. And certainly people have been talking for a long time about making routine testing an indicator of healthcare, which it is not yet in most settings. So I think that was the essence of our track. And because of the interest in getting the perspectives of other providers, from a personal point of view, I would say that next year's meeting could really try in a very different way to bring together an audience of people who are charged with implementing this, but it's not their main work, and really have increased the dialogue with them. Thank you.
Thank you. Our next presenter will be Barry Zach from the Bridging Group, discussing a special cross-cutting session on viral hepatitis and HIV prevention, diagnosis, and access to care in correctional settings.
Good morning. It's always nice when corrections is on the table, so I really want to acknowledge the summit for putting it out there. Those of us who have been working in this field for a long time. It's usually the session at 7 in the morning, the last day of the conference, or 11 at night, the last, But I also want to do a real shout out for those of you who saw the Medea project last night. That was just, it brought into not just the reality of what so many of our constituents deal with every day, but also just brought in, just dare I say, when your congresswoman is talking about love, she's talking about the spirit, the heart. I think that just brings an additional dimension that often is not at our scientific conferences. So just a real shout out to that. I guess this context. This is this is the corrections one. The context. How many people here? I'm not going to out you. Okay. How many people here have ever spent any time in a prison or a jail? Now that could be as a provider, as a visitor, as those days of civil disobedience, those days of being at the wrong place at the wrong time. Okay, so if you looked around, there's quite a few people there, and I think that's really important to again bring that into the room when we start talking about HIV and viral hepatitis. I challenge to find a more challenging environment where you're talking about prevalence rates of upwards of 40, we're talking about IDUs 60+%, talking about in the 12-city project, we're talking about HIV prevalence rates from 1 to 15% in our jails. So we're talking about a population where not just we're talking about high prevalence, but also a unique access to a population that oftentimes don't access in the free world. A real sad reality. I remember in the days when the infirmaries were the death rows of HIV in the late 80s, early 90s. There were more people dying in the prison hospitals, in the infirmaries, than there were on death row. And I think we're starting to see that now with hepatitis as well. That HIV, we're seeing very strong survival rates, but with hepatitis, we're not doing as good a job on the inside for a lot of the obvious reasons. So we had a very interesting workshop yesterday. Let's see if I can master this. Here we go. We had a couple of sessions. Wow, that really tells about my eyesight. That's real small. Okay, from Rhode Island, we're talking about the feasibility and acceptability of HCV testing. Again, really, really important. Is it can we do it? And I think it's pretty clear it is a feasible setting to do testing, to really do screening. Sadly, I will say that. Not from this presentation, but I think what is getting pushed off the table is primary prevention. Prevention now is all done in the context of testing. So basically, I don't think we're doing a good enough job in working on those people who are testing negative. It's sort of like in the prison and jails, the saying is no news is good news. We do mass screening, and if you don't hear results, just assume you don't have it. And that's our policy of just of testing, of giving results. So I think we have some lessons there. So in Rhode Island there was a pilot of rapid testing and it looked very, very good, as well as a follow-up. And again, it's one thing. It's very sad when we can say that we have people in prison and jail who are healthier, who are safer on the inside than they are on the outside. And that's a real sad statement about our lack of a health system in this country. But I think a real emphasis that we're starting to see, and we'll see a couple of other presentations, is the focus on continuity of care. We heard a presentation in Washington, D.C. about peer navigators, about working in the community, and again it was just very interesting. I don't know if Terrence is here, but just about how peers are just critical actually, is this peer navigators? This is New Mexico. No, this is Washington, D.C., and using peer navigators in the neighborhood to increase testing amongst people with a history of incarceration. So very, very important, again, the role of peers. Again, think of the context in a prison and jail, a correctional setting, where the whole system is based on mistrust. Let me say that again. You're talking about working in a system that the whole system is based on mistrust. And we're not talking about just correctional officers and people doing time. We're talking about even amongst everybody. So using peers is a real viable vehicle to reach out to, whether it be for testing, for continuity of care, finding people for follow-up. Project ECHO is very, very interesting, looking at a peer education model in New Mexico Department of Corrections. And it's not just like this peer training, but what I found very, very interesting and very unique is using telemedicine for ongoing education and supervision of the peers. So again, keep in mind, think about where you're from and think about where the prisons are in your community, in your state. They're typically not in urban areas. I think there's like 2 prisons left. Sing Sing and San Quentin are the 2 prisons left that are relatively in an urban area. Everything else is way out in the boonies and very hard for access, both for clinical access, getting people out there, as well as talking about continuity of care issues, because people don't stay in where that prison is located once they get released. So this model in New Mexico, very interesting. We'll look forward to hearing more about that Project ECHO, with using telemedicine as a vehicle to stay connected to the peers. And finally, in Wisconsin, looking at some of the HIV testing treatment services in Wisconsin. Again, you can take a look. It's basically a low prevalence state, but talking about some real opportunity. Again, I use that word, and I think those of us who have been doing this work for a long time, we often use that word. At the international conference, the executive director of UNODC, United Nations Office of Drugs and Crime, got up and said, let's not look at prison as an opportunity for anything. And I think that it was a really important message. It got a lot of us to really open up our eyes and go, that's not a policy. We should, let's not lock people up in order to treat them. Even though we know what the implications are. So as far as having access to this population, and access to a population that, 1, has high histories of risk behavior, and 2, do not access the medical care system in the community. So I think this is a sad reality when people are healthier and safer on the inside, that the data are quite robust as far as looking at viral loads and CD4s, that you can get them suppressed on the in the viral load suppression undetectable on the inside, and then on the outside when they return they're skyrocketed. And I think that's it. So I thank you very much. Again, next year I look forward to a whole series on corrections, and maybe we'll include STDs and TB along with viral hepatitis and HIV.
Good morning, everyone. I'm Neena Mani with the forum, and it's my pleasure to invite the Track C, the Category C rapporteurs for Outcomes and Evaluation, Dr. Carol Brogard from the Division of Global Health, UCSF, as well as Dr. Rochelle Walensky from Harvard Medical School.
Okay, good morning. So Rochelle and I covered a very robust session also with 3 different sessions looking at outcomes and impact for broadening of HIV testing and HCV testing. So we have a number of slides, and we're really just going to go to the high points, so don't worry, and all of this will be distributed, and I think, and available to participants. So Dan Church from the state of Massachusetts covered their surveillance data, and interestingly, they show that a large number of people have been identified as being HCV antibody positive. In fact, over the period of 3 years, there were 34,000 individuals who were tested positive. But importantly, 35% of them had never had a follow-up nucleic acid test to determine whether or not they had chronic infection. And this is a theme that we've seen when, in fact, people do look at HCV antibody testing. And also importantly, that even of those who had nucleic acid testing, there was a significant lag time to that occurring. What was important is that from this presentation, it really speaks to the need for broader provider, not just physician, but the full range of providers who are involved in caring for individuals and will be doing broader testing on how to do testing and what the testing means. Scott Holmberg from the Czechs, the chronic hepatitis cohort study, which is involving 1.6 million individuals who are in 4 different integrated health systems in the United States, began with a retrospective look back. And based on what we know about the demographics for both chronic hepatitis B and chronic hepatitis C, it was clear that from the number of individuals who have been identified in their electronic medical records, that only 66% of those with chronic B and probably about 50% of those with chronic hepatitis C have been identified. So there's a need to do more screening. What was worrisome too is that because up until today, the recommendations to identify those with B and C are based on risk. That even when an individual in the medical setting had chronic elevated liver function tests, whether it was a one-time or it was a repeated elevation, even in that setting, in half or less than half the time, were individuals getting follow-up for chronic hepatitis. So that comes back to how important provider education is going to be. We can't just issue recommendations. And then even when individuals in this setting had had HCV antibody testing, again, only about 35 to 40% of those had had the follow-up nucleic acid testing. Then Bacchus from the VA, looking at their national registry, they've identified about 170,000 individuals with hepatitis C over the last decade. And importantly, what we've seen over the last decade, because there have been very low treatment rates, not just in the VA, but everywhere there have been low treatment rates because of the difficulty with treatment. But here we are on the eve of a sea change in therapy. But over this past decade, with the 170,000 individuals identified, they've seen a 2-fold increase in diagnoses of cirrhosis. At the beginning of the registry, hepatocellular carcinoma diagnoses were almost negligible, and that's risen to a total of 4,000 cases, and that mirrors the tripling of the HCC rate we've seen in national cancer registries, and there's been a twofold increase in death. So here's this cohort that's moving along, and we're certainly seeing the morbidity and mortality. And then Michelle Manos from Northern California Kaiser, which covers over 3 million lives. They've had an active viral hepatitis registry. And then even when you have an EMR and a registry and really major efforts across a health system, there's still underdiagnosis. Again, like in the Czech system where the numbers of individuals with B or C have not been identified. But importantly, and this was a recurring theme, is that when individuals with Hep C are identified, surprise, surprise, the majority are in the birth cohort, again, validating the need for the birth cohort testing recommendations. And now I'll turn it over to my co-moderator.
So this next study was from the New York State Department of Health, where they looked at 5 city boroughs in New York City. And this was really a new method to look at disease burden, identifying regions that had the highest disease burden really on a map, and looked at the 7 diseases, including HIV, TB, STDs, Hep C, and mapped the areas that had the highest 20%. So it wasn't that 20% of people had all 7 diseases, but in fact looked at the boroughs that had the highest 20% of these diseases. They partnered with FQHCs and noted that in 7 zip codes, all 7 diseases had the highest 20% burden. And this was not necessarily surprising, but it was really potent to see on a map and to really be a strong rationale for integration of services rather than a siloing of these services. And then again from New York City, there was some nice data looking at how much HIV and STDs were in the population that they were finding. So declining annual incidences of HIV over the last 5 years, increasing incidences of STDs, but what was nice to see actually was the rising incidence of co-infection. So why was that nice to see? It was nice to see because, and that rising incidence was 39% in 2005 were diagnosed at the same time, STDs and HIV, and that increased to 53% being diagnosed at the same time. But what that actually meant or suggested was that there was an increased amount of dual screening, so that people were actually screening for HIV when they were screening for, when they were looking at STD clients. So that was our first session in Track C. We move on to the next session of clinical and cost effectiveness research, and I'm going to pass it back.
And Dr. Walensky presented on generics. And as I think many of you know, given that some of the earliest HIV drugs were approved back in the mid-'80s, some have already had their patents expiring and many more are coming. So Dr. Walensky looked at the trade-off of cost and improved adherence associated with decreased pill burden, but looked at the cost of the branded as compared to generic antiretroviral therapy. And branded, once generics hit the market in the US, branded will not be considered to be cost effective if you're using the threshold of $100,000 per quality adjusted life threshold. So a change to generic antiretroviral therapy could save the US healthcare system about $920 million in the first year alone. And that's a trade-off we're going to need to consider if we're moving to routine HIV testing. We're trying to identify all of those who are tested, get them into care. Then as a system, are we going to be able to afford branded therapy or not? And what could we do, and how many more individuals could we care for, not just for HIV, but when we're, as we've been talking about over the last few days at this conference, how are we going to be able to test for chronic hepatitis C and be able to then pay for therapy? So it was a very important presentation. It's thought-provoking, and it's something we, as a provider community and as policymakers, are going to need to deal with in the years to come.
Great. Okay. So Kim et al. From Johns Hopkins was looking at a cost analysis of several programs in 5 cities to look at what in linkage to care, HIV linkage to care, and looked at 2 different thresholds of what these programs for linkage to care would have to achieve to reach cost saving as well as to reach cost effectiveness. And they found in these programs that they'd have to avert about 1 HIV infection if the cost per HIV infection was about $350,000 per case, which is frequently cited, and that the cost effectiveness threshold was that they would have to achieve 3 increased qualities in health for each of these programs. They didn't go further yet, and I think that's planned, to look at whether they can achieve these thresholds, but they seem to be achievable, that these were, it might be possible that we could avert one transmission and potentially save 3 qualities. Study from the DC Department of Health looked at linkage to care in medical care management sites compared to non-medical care management sites. Linkage was somewhat better at 3 months in the non-medical care management sites. And that was likely due just to comparisons between CBOs and places that have care integrated. But at 6 months, linkage was better, as well as engagement in care and viral suppression were better in the, where there was medical care management versus where there was not. And then they're now in that study looking at effective ways to potentially scale up, which would be terrific. A really nice study from Laffer et al. At the AIDS Institute looked at the return on investment in PMTCT, there's a typo there, sorry, PMTCT programs in New York City over the last 10 years. And I really particularly like this because so much of what I do in cost is not cost saving, and this one actually showed that it was. So they defined, he defined return on investment as HIV medical care costs averted over expenditures for services over the last decade, and included costs of the anticipated 750 averted vertical transmissions that have likely occurred over the last, or not occurred over the last 10 years due to PMTCT, and showed that the return on investment in these programs was about $4 for every dollar spent. So that was really nice to see. Bruce Shackman from Cornell did a survey of the cost effectiveness literature in HIV, in Hep C screening. He reminded us, as I will remind many also, that the cost effectiveness does not mean cost saving, and that if we're going to be screening for hepatitis C, we can't expect to save money. In fact, we hope to spend money and improve people's lives in doing so. So he highlighted 3 studies that looked at Hep C screening in the birth cohort from ages are born in between 45 and 65. The incremental cost effectiveness ratios range from $4,200 per quality to about $3,800 per quality. That wide range of differences can be attributed to whether people use triple therapy in their analyses versus not triple therapy in the analyses, and all essentially showed that HCV screening in the birth cohort was going to be a very cost-effective intervention in the United States, regardless of the treatment that was available, 2-drug or 3-drug. Data from the CDC looked at, from Morgan et al. Was a meta-analytic review that looked initially at 30 studies down to 18 studies that had adjusted for effect measures. In that review, they showed that SVR was associated with a 75% decrease in the relative risk of hepatocellular carcinoma, so that was quite potent, and that the rate of HCC was 0.3% per person year with SVR, and that was considerably higher, 1.6% per person year without SVR. And then our final session, I will turn over.
Okay, so in the final session, there was a very interesting report from CDC trying to estimate the proportion of injection drug users in the general U.S. population, and this really hasn't been done before. And they used data from a number of different national surveys, and you can see that listed here. And the meta-analysis across those studies of individuals who report injection drug use and then matched with census data, and they came up with, it's hard to see here, the 2.6% of the U.S. population had used injection drug use at some point, and that 0.3% had been an injection drug user in the last 12 months. If you looked at the difference in gender, there was a ratio of about 3 men to every 1.5 women. And then if they looked at then calculating what the rate of diagnosis would be for HIV, it was 77 per 100,000 injection drug users who are HIV infected, but 16 per 100,000 non-injection drug users. So again, a significant risk. In New York City Health Department, King looked at the expanded HIV testing from beginning early scale-up projects in 2006 to currently, and it was really amazing. In 2008, there were 30,000 tests done. In 2010, there were 170,000 tests. Over 500,000 tests have been done since the call for routine testing in 2006. And new diagnoses went up from 250 in the city in 2006 to 580 in 2010. Importantly, the concurrent diagnoses or late diagnoses of HIV and AIDS has fallen, so we're finding individuals earlier. And most of these individuals were linked to care within 90 days, and that was based on surveillance of CD4 and viral load counts. Another really interesting study came from the University of Cincinnati, from Keesham, and they'd noticed that over the past decade there had been an increasing number of individuals hospitalized with infective endocarditis. This was something that all of us who trained 30, 40 years ago in major cities saw, but this wasn't something that had been seen in Cincinnati, and this was really the sentinel flag for injection drug use moving into the heartland of the country. Amongst these individuals, what was disturbing was that so many were not tested for HIV or hepatitis C, and so many of these individuals did not even have tox screens to identify their substance use as a reason for their admission and their underlying mortality. What was important here is that there's been an increasing prevalence of HCV amongst those admissions, and this is probably an underrepresentation because so few were actually tested for Hep C, from 3% at the beginning of the decade to 16%. And what was striking was the in-hospital mortality, too, of 28%, and a relatively young cohort.
So these next two studies are really discuss how much scale-up has been going on in it and HIV testing, and really some successes there. The first was Unity Healthcare in DC. They have experience in working in 29 medical and non-medical centers over the last 2 years. They've called routine testing the fifth vital sign, which I really liked. If you're going to take a pulse, you should also take an HIV test. They did 23,000 rapid tests over the last 2 years, had a case identification of 177 testing positive, and they were able to immediately conduct CD4 counts and viral loads, and they had 86% linked to care, which I thought was terrific, especially since some of those non-medical settings are much harder to link to care than in the medical settings. Rapid testing from this experience was acceptable, easy, and largely universal. The next was in the AIDS Foundation of Chicago. Also innovative ways to think about HIV screening in non-clinical settings. Over an 18-month period of time, 6,700 people were tested over 330 days of testing and at local public aid offices. Almost half were first-time testers, so that was nice to see. 38 screened positive, 63% of those confirmed, and 55% linked to care. Also speaking to the challenges when you get somebody out of a non-medical setting of really getting them back into a medical setting to confirm their diagnosis and link to care. And then this final study was, again, Church et al. From Massachusetts Department of Public Health, looking at the mortality trends among people with hepatitis C. They looked at the 88,000 Hep C lab reports, which is a mandatory reporting in Massachusetts, and looked at 1.1 million vital records in the death registry. They crossed them and found 8,500 matches. Approximately 10% of reported Hep C cases had died within 17 years. The mean age of death was striking. It was 53%, all-cause mortality for those who were Hep C positive, and 75 years for those who were Hep C negative. The annual mortality rates among those with Hep C were highest among those aged 50 to 54, again consistent with people dying who were within that birth cohort. So in conclusion, I want to thank the forum, Veronica, Ken, John, for putting together a great meeting and a great session. We had a great track with a vibrant discussion in all of our sessions. Our apologies for not including all of the talks that were given. They were really all quite terrific. I think my general overview of the last 36 hours in these tracks has really been first with Hep C, that we are underdiagnosing it, we are undertreating it. It's an impending health problem. I sort of feel like I did 6 years ago, sitting in, I'm going to forget which hotel, at this meeting, thinking about HIV. I feel like we're drinking from a fire hose here, and we have to turn off the spigot. The data show that the epidemiologic and cost-effectiveness data support screening for Hep C in the birth cohort, and we need to push forward to try and do that. On the HIV side, I think the news is a little bit brighter. We have been very productive over the last 6 years, 2 years since the last meeting. Scale-up of screening has occurred in many settings with earlier case identification, more frequent screening, improved linkage to care, and yet there's still quite a bit of work to do with HIV as well. So with that, I will turn it over and say thank you.
And now I invite Category D, Access, Linkage, and Retention in Care, Drs. Maggie Zornogorski from the Department of Veterans Affairs, as well as Dr. Joe Burridge from Indiana University School of Nursing, to give their summary.
Good morning. Okay, we were charged with distilling all of this information that we'll report in the next 7.5 minutes. Basically from Category D, access, linkage, and retention in care. And within those, in that category, there were 4 tracks: one that addressed policy, one that addressed models for HCV workforce, one that addressed current and future providers, and one that addressed models and for linkage to care. So, the first that we had to talk about was access to care for persons with HIV and viral hepatitis in terms of a policy forum. It was an excellent group that presented, and we're just going to give you the distilled versions of what we got out of all of the presentations. First was that the Affordable Care Act actually should equal significant opportunity for improving access to HIV and HIV hepatitis prevention, care, and treatment. Success depends on active involvement of HIV and viral hepatitis communities. Ryan White reauthorization may offer the opportunity to provide some targeted support for viral hepatitis, which was good news. And also investment in viral hepatitis surveillance and care systems is needed to replicate the HIV success that we've seen so far. Also in that same forum, we found that action was needed to ensure seamless linkage to care for recently released individuals from correctional facilities, which we've already heard earlier. It was interesting being last to listen to some of the cross-cutting themes that we didn't have any idea were going on since we were in the same room. And as you listen to this, you see the different themes arising again. Also, we saw that data showed that Medicaid patients are disadvantaged in receiving timely interventions and timely initiation of ART, and also that community health centers are actually a very underappreciated safety net that we really need to grow and also refine. Models for HIV workforce. These were some really interesting presentations as well. And one of the things that really popped out was that implementation science approaches really need to be used from a refined approach to evaluate and disseminate best practices and effective models so that we're all on the same page in the way that we do this type of research. Peer support was also found to be resurfacing as a successful model, and I'm dating myself when I go back and revisit the whole fact that we did this many years ago, but now we're also finding that we have no data to support its effectiveness. So we need to go back and do that. Telehealth, echo, scan echo, clinical pharmacy trainings are innovative methods to expand workforce capacity, and we've also heard a little bit about that earlier this morning as well. One of the major issues of concern that came up in the sessions was the sustainability of the echo projects. And I'm going to turn this over to you.
Thank you, and thank you to the forum for putting on such an excellent conference. It really was wonderful. So during this session, one of the themes was who are and who will be the providers. And this was actually a discussion amongst a number of subject matter experts led by Steve Boswell and John Bartlett. And there was a lot of cross-cutting themes here, but one that stood out to us was that the medical home model, and that the integrated model is the future of HIV care, and we really need to start moving to this if we want to improve the care for those that are infected with HIV. And to do this, all members of the team need to be working at the top of their competency level. We need to make sure that we have a team approach where everybody is working together to provide the best care. There is also talk about the use of nurse practitioners and physician's assistants and how that will increase in the future, and especially in rural settings, to take care of HIV patients. In the last session, which was the linkage to care and retention in care rate, retention in care session, the Gardner cascade came up numerous times, and it really highlighted the need for more effective linkage and retention to care. I think in this country we've done a fairly good job at identifying those with HIV. We still have work to do, but we really have scaled up our routine HIV testing efforts. But now we need to make sure that not only are we testing folks, but we're making sure that we're linking them to care, retaining them to care, getting them on antiretroviral therapy, and making sure that they're undetectable to get a better handle on this epidemic. So there were a number of models that were suggested during the session that may help improve this leaky cascade. And one was using highly trained patient navigators as a useful tool to ensure linkage and retention in care. And I think there was an excellent example of a program that's in New York City working with Hep C patients to ensure that patient navigators were helping ensure that linkage to care for these patients. Also, we talked about the use of public health surveillance data to find individuals that are out of care and link them into care, and there was 2 successful models that were discussed during that session, both in Seattle and New York City. And we also talked about the way the VA can be a leader in integrated care and can be a model for the way HIV care should be provided in the US. It's hard for me to say that without smiling, but so once again, thank you to the forum for such a wonderful conference, and that concludes our session.
The last presentation will be on the Category B, Prevention Models category. I'd like to invite Cornelius Baker from the National Black Gay Men's Advocacy Coalition and FHI 360.
Good morning, everyone. Thank you. And first, I'd like to obviously thank the forum for, as everyone has mentioned, a good meeting that we've had here, and especially to Ben for doing all the legwork around. I get to do the wonderful presentation, but he did all the work, so it's great. In prevention, this is really a great moment. We have so much opportunity, but we also have so much challenge. And so I think it's fitting that we're ending our time talking about prevention and where do we go. In the prevention model session, Dr. Mayer began by really emphasizing the great moment of opportunity that we have and looking at pre-exposure prophylaxis for HIV prevention, giving an overview of the science and where we are with trials that have been conducted and the trials that are ongoing. But it's very clear to us already that clearly, we've already had the model proven to us with 076 in the prevention of mother-to-child transmission, but that what we know is that for this to be effective, it all really relies on adherence. And so beginning to look at then not only how do we improve adherence and how do we help make these drugs effective, but also to whom and with whom. There were studies looking at this in DC, looking at knowledge also of PrEP, and up in willingness to be engaged in PrEP. And in DC, PrEP awareness was low, but the willingness to take it was high. There was a lot of discussion in that session about a clinical tool to assess potential PrEP users how it could be useful. It engaged a very interesting dialogue. One of our colleagues, Wakefield from Seattle, brought up the important point of, well, if you have a clinical tool to determine who should have PrEP, what happens when someone wants it who doesn't fit within the tool? Or how do you prevent the tool from becoming a screening factor that keeps people from accessing it or stigmatizing it and identify only most highest risk? The providers are aware of PrEP and the PEP guidelines, but they're least likely to prescribe it. There's also discussion in the sessions about who are our prevention providers. And so we have a cohort that's well established and defined when it comes to HIV care, particularly if it's based on people who are HIV positive. But the whole realm of people who are HIV negative and at risk, who are their providers and how are they getting trained? How are they being engaged in this system to take advantage of the opportunities that we have at hand? In New York, a majority of potential patients had never heard of PrEP. And so we know that this needs to be accompanied by education and there needs to be an awareness of the limitations. There was both in session as well as hallway conversation about direct-to-consumer advertising. How do we market PrEP? As a longtime advocate and somebody who is very much engaged in helping to develop direct-to-consumer advertising, I think it's really important that we step back and recognize the context of how we move that forward and why. Because particularly in communities of color, people were not being prescribed treatments that could benefit them, and they were not aware of them. And so while we know that some of the direct-to-consumer advertising has gone way over the top, it's better that people do know, and they weren't being prescribed. So we need to look at how do we really begin to educate the public about PrEP. And then we looked at some of the policy issues in that session, and Sean Cahill from Fenway talked about treatment as prevention and PrEP and how they can be synergistic and how we should be looking at the coming implementation of the Affordable Care Act and how it can provide access to PrEP as a defined critical prevention benefit under the essential health benefits components of the Act, looking at successes in Massachusetts. So we have, again, a model that we can look at in how Massachusetts has implemented its healthcare reform to look at where the opportunities that we can gain from and what are some of the challenges that we're going to have nationwide. And then there was provision of, and then looking at provision of PrEP to gay men and transgender populations needs to be in a culturally competent manner if it's going to be successful. So We also looked at one of the signal trials in PrEP, IPREX, and how do we measure the PrEP use? Again, going back to, adherence is destiny. And there are many ways we could look at the gross level of drug to see what's present, but that's very difficult. Self-reports are unreliable. And so looking at how do we actually look at PrEP use and assure that there is adherence as we begin to roll it out on a larger scale, recognizing that the 2 study sites in the United States were unique in the IPREX trial, had a high level of adherence, but it also had a very highly educated and older group of people who were in the trial. And if we're going to be effective with the benefits of PrEP, we're talking about a less educated population that is far younger and is in less stable conditions. So monitoring and engaging around adherence is going to be a lot more important. We heard from the CRUSH project on connecting resources for urban sexual health, that PrEP is highly acceptable to the youth that are being interviewed in that project, but there was concern about side effects are a big issue, and daily pill taking is not such a big issue, but there are questions as we begin to really engage with this younger audience about how to maintain them if they have questions about the side effects. And then during the discussion, again, I just want to, everyone talks about a tool, and I just want to again emphasize that engendered a lot of discussion about what such a tool and what such training would look like. There was also discussion about how long do we expect people to use PrEP. And so is this really something that we're thinking of as a lifelong therapy, like HIV treatment, or is it episodic? So, we heard about one person who was in a study, who's using PrEP while he was highly sexually active, is now in a monogamous relationship and has stopped taking PrEP. What happens when people are engaged in serial discordant couples? Should they, relationships, should they use it throughout their entirety of their relationship? Or do we look at it as something that people will use circumstantially? And then again, educating both providers and consumers about all of these issues is going to be critical. Our next session was about population approaches to prevention, and there were a number of good presentations there, and I had the good fortune of moderating it, so they were all excellent. And and we heard from a project in San Francisco, UFO model, You Find Out, a study of young IDU clients, and the program, and all of these programs are really talking about how do you engage in a non-judgmental harm reduction model. This was youth-centered. There was real emphasis there on defining and tailoring a program that's for youth, and that when you mix younger people and older people together, the results are not as good. And in fact, a lot of consequences can develop from that. So really developing programs that are population and audience specific. The HOME Project engaged patient navigators in New York to link patients to HCV and HPV care and providing vaccination for HPV. And then the Male Center provided culturally competent, and that's in in Boston at the AIDS Action Committee of Massachusetts, for project focused specifically on gay men to provide culturally competent care. And then the Asian Health Coalition in Chicago, a real successful model again of using patient navigators. So as we think about Affordable Care Act, looking at how community-based organizations, community advocates become part of the linkage to care for all of our approaches. And I'm just going to wind up on really looking at a critical population, as Dr. Fenton highlighted in his opening in the United States, HIV infection and disparities among African American gay men, with a 34% increase among infections and overall, but 48% among young black gay men, and 22% more likely in the U.S. You've all heard all the data and statistics. I want to highlight a couple of things, though, that in this, that, and as we think about our work over the next 4 years, both in terms of implementing the Affordable Care Act, but as we think about the fiscal cliff and what is going to be the foundation of our society, that the social and environmental factors are equal contributors here. It's not solely about behavior. And I think, you know, if any of you have seen the movie Lincoln, which is so brilliant, you know, we have to begin to put where we are in a clear historical context. And we also have to relate it to, you know, being a young black male right now, we talk about high rates of unemployment. We talk about the 8% in our country. Well, for black men under 30, unemployment is 30%. And so, and we're talking about homelessness. And we're talking about a lack of education. We're talking about for young black gay boys and transgenders being bullied out of school. And so when you are in those environments, and when we talk about the escalation of the epidemic in the South, we're talking about, you know, as my partner who's supervising attorney at Lambda Legal says, you know, if you're in Georgia or a state that touches Georgia or a state that touches a state that touches Georgia, none of those states have protection for gay and lesbian people. You can be fired at will, you can be kicked out of a house, you can be, all of those things are legal. And that is the context of the epidemic. PrEP will not resolve that. And so we have to be very clear that our work will entail addressing social and environmental factors. And so, and that's going to have to be part of how we explain this epidemic. And so, and then we recognize also that in black communities, and you know, as my grandmother would say, when America gets a cold, black America gets the flu. So it doesn't just affect black young boys, but also black women, black heterosexual men, and it's an epidemic that is generalized throughout our communities. But you know, and we heard this over and over again in the studies from both home and the DC Department of Health talked about how communities are really struggling and populations are really doing their best with condoms. Their condom use is high. They've adopted our prevention messages, but they are still in environments that expose them to risk. And so we're going to have to look at how the Affordable Care Act helps, but we're also going to have to look at a societal foundation that also helps. And so thank you very much.